Hi everyone, it's Emily Bach. I'll be presenting my discussion board on the benign GYN patient. History of present illness. Molly is a 30-year-old gravida 0 presenting with complaints of irregular periods and pain in lower abdomen and lower back that radiates to both legs. Her pain starts a week before her menses and then subsides a few days after her bleeding begins. Her menses are heavy and she passes clots. Occasionally her pain is so severe that she must miss work. She is sexually active with her fiancé and uses condoms. She reports many years of dyspareunia, which seems to be worsening. She denies history of abnormal PAPs or STIs. Complaint. Molly's chief complaint would be secondary dysmenorrhea and menometrorrhagia. Secondary dysmenorrhea is painful menstruation in the form of recurrent cramping or dull, continuous aching pelvic pain that occurs just prior to menstruation and resolves within a few days of menstrual bleeding. Menometrorrhagia is abnormal uterine bleeding consisting of heavy and irregular bleeding. Subjective data. Important subjective data to obtain from the patient would be completing a thorough medical, surgical, social, and family history, including menstrual history and sexual history. This includes inquiring about her urinary, gastrointestinal, gynecological, musculoskeletal, sexual, and psychosocial symptoms. Does she experience any urinary frequency, urgency, painful urination, hematuria, or flank pain? Does she have any nausea, vomiting, diarrhea, constipation, pain with bowel movements, or difficulty having a bowel movement? Has she ever had a history of a pneumothorax or hemothorax? Does she experience any chest pain, coughing up blood, or neck pain? And any history of pain with sex or infertility? The quality of her pain, timing, radiation, location, severity, setting, associated symptoms, and any alleviating factors related to her dysmenorrhea and pelvic pain should be asked about. Objective data. The physical exam should begin with the patient's vital signs and general overview of the patient. The patient reporting pelvic pain should have an exam of their back, extremities, abdomen, and pelvis. The pelvic exam should include examining the external genitals, performing a cotton swab test, examining the pelvic floor muscles, examining the patient's urethra, bladder, and rectum, as well as completing a bimanual exam and a speculum exam. The examiner is looking for any focal pain or tenderness on exam, a pelvic mass, any immobile pelvic organs, rectovaginal nodules, uterosacral ligament nodularity, and any adnexal masses. Labs. Because the patient is of reproductive age, a pregnancy test should be performed to rule out an ectopic pregnancy as a cause of her pelvic pain. A urinalysis should also be performed to rule out a UTI, as that can cause pelvic pain, back pain, and urinary symptoms. A CBC should be done to determine if an infectious process is likely, such as appendicitis or an abscess, including if PID may be present, as well as looking at if the patient is anemic related to her heavy bleeding. Vaginal cultures for chlamydia, gonorrhea, and trichomonas should be obtained on all sexually active patients to rule out an STI and/or pelvic inflammatory disease. The first differential diagnosis is endometriosis. Diagnostic testing should be a transvaginal ultrasound to look for ovarian cysts and any endometrial biopsies. The first-line treatment includes an NSAID like Motrin, so she could take maybe 600 milligrams of Motrin every 6 hours as needed for pain management, as well as a hormonal contraceptive like Nadazia is a recommended first-line treatment for endometriosis. Her oral contraception should be taken continuously so she doesn't have any breakthrough bleeding or monthly menses. That should be trialed for 3 months, and if it's successful in reducing her pain and symptoms, then it should be continued for 6 to 12 months. Surgery, specifically excision surgery, is the gold standard for diagnosing and treatment of endometriosis. Surgery is often necessary for patients that are not responding to medical treatment or have severe symptoms that are impacting their daily lives. Excision surgery is preferred over ablation surgery. Excision is when they actually cut out the disease itself, as opposed to an ablation, which is just cauterizing the endometriosis, and this is found to have significantly better results. Lifestyle modifications that should be implemented as well include regular exercise, getting adequate sleep each night, a diet high in vegetables and omega-3 fatty acids, reducing alcohol, coffee, and red meat consumption are all lifestyle modifications that have been found to improve endometriosis symptoms. Education should include the disease process, symptoms, treatment options, resources available, and if left untreated, that endometriosis can progress to infertility and chronic pain. Referrals should include a gynecologist for surgery potentially, possibly a reproductive endocrinologist for infertility management, and if they have urinary or bowel symptoms, it would be appropriate to refer them to a urologist or even a colorectal specialist or GI. Follow-up includes reevaluation of symptoms and treatment progress after 3 months of therapy. I want to just touch upon that GnRH agonist, or Alyssa. As a patient who's had endometriosis for many years and has actually been treated with Orilissa, many endometriosis specialists advocate against GnRH analogs because of the potentially harmful side effects. It's estimated that roughly 10% of patients treated with these medications will develop depression, mood swings, suicidal thoughts, and or commit suicide. During the Orilissa clinical trials, which had around 600 women participate, 3 actually ended up committing suicide, 3 had experienced suicidal ideation, and then nearly 11% of all women reported having symptoms of suicidal thoughts or self-harm ideations, depression symptoms, or significant mood swings. The second differential diagnosis is an ovarian cyst. This should also be diagnosed with a transvaginal ultrasound, which will look at the size of the cyst as well as characteristics and determine what type of cyst it is versus a mass. Pharmacological treatment should include NSAIDs or even opioids for pain management, as well as oral contraceptive pills to help prevent new cysts from occurring. The oral contraceptive pills will not help shrink the current cyst, but will help prevent future ones from forming. Ovarian cysts typically resolve within a few menstrual cycles on their own without any treatment intervention. Occasionally, surgery is needed to remove the ovarian cyst. This is if it's greater than 10 centimeters in size, continues to grow, persists past 6 months usually, 6 to 12 months, and medical therapy fails to resolve the patient's symptoms. Follow-up includes a transvaginal ultrasound every 6 to 12 weeks to monitor the size and appearance of the cyst. Education for the patient should include that ovarian cysts are not cancerous. They should be educated on potential complications like hemorrhage, ovarian torsion, pelvic pain, rupture, and concerning symptoms to watch for and when to be evaluated. Referrals can include either a GYN or general surgeon if surgical intervention is needed. They should also possibly refer to a reproductive endocrinologist or a GYN oncologist for further evaluation if necessary. Important information that I will be adding to my pocket guide for this week includes creating a chart of signs and symptoms comparing endometriosis, ovarian cysts, and fibroids, as well as diagnostic tests and appropriate treatment options. This is a good example of a chart that defines the differences between endometriosis, adenomyosis, cysts, fibroids, and polyps. Here are the references I used while completing my discussion board post. I hope you enjoyed my presentation. Thank you.